Well, let me say welcome to this year's ALS Respiratory Symposium. My name is Ryan Rezik. I'm the Executive Director of the ALS Association Western Pennsylvania chapter, and I'm also the MC for today's symposium. Today, we'll learn about the tools and techniques that are used to help people living with ALS manage their respiratory health. We'll cover a broad range of topics, including medical considerations to improve breathing and equipment that can support productive respiration. Our three topic experts today are Kimberly Penrod, a respiratory therapist at Laurel Medical Solutions, Carol Chieffe, a nurse at the Allegheny Health Network's ALS Certified Center of Excellence, and Larry Locanti, a respiratory therapist at Philips Respironics. Our first two presentations today are recorded, and our last presentation will be live. All three presenters will join us at the end of today's symposium to answer your questions. Please feel free to type your questions, as I mentioned, in the chat, and we'll ask the presenters of those questions at the end. As a reminder, please keep your line again muted during the presentation to ensure a minimum of background noise. All right, before we get started, I want to take a moment to thank our sponsor of today's symposium. Today's partner level sponsors are Allegheny Health Network and Highmark Blue Cross Blue Shield. And our premier partner for today's symposium is Philips, a manufacturer of personal care, household, and healthcare solutions. Through their subsidiary Philips Respironics, they produce a variety of respiration solutions, including those used by people living with ALS. I should note that Philips Respironics headquarters are actually based here in Western Pennsylvania. They're located in the Bakery Square section of Pittsburgh. Let's take a moment to watch a brief video from Philips.
I'm Alina DeGraff. I am the National Business Leader with Philips Sleep and Respiratory Care. We're so passionate about supporting the ALS community and families of ALS patients. And we're extremely fortunate to be able to provide products and services to ALS patients and the ALS community. But at the same time, it's not going fast enough. And we would like more. We would like better care. We would like a cure. And it's not there yet today. So we're here to support the overall effort for ALS.
All right, thank you again to Philips, Allegheny Health Network, and Highmark Blue Cross Blue Shield for their support. Let's go ahead and get started with our first presentation entitled Respiratory Needs in ALS. Our presenter is Kimberly Penrod, a registered respiratory therapist with Laurel Medical Solutions. Laurel is one of our chapter equipment loan program partners, and Kimberly's worked there for 5 years, helping a wide variety of people manage their breathing throughout Western Pennsylvania. Her presentation will focus on some of the equipment used to support breathing and techniques to improve lung function. Let's go ahead and get her presentation started.
Hello, everyone. Welcome to Respiratory Needs in ALS. My name is Kimberly Penrod. I am a registered respiratory therapist. I graduated from YTI Career Institute with an associate's degree in specialized technology respiratory therapy in 2015. I've been employed with Laurel Medical Solutions for over 5 years. Laurel Medical is a loan closet for PALS, and we work side by side with ALS Association to provide the best possible care for ALS patients. I'm going to take my face off there. Alrighty, let's get started. The objectives. How does ALS affect breathing? Early respiratory symptoms. Deep breathing exercises, huff cough, abdominal thrust, a cappella, chest vest, secretion clearance. What is a BiPAP? Commonly used BiPAPs and masks used with BiPAPs. How does ALS affect breathing? ALS causes weakness in various muscles of the body, including the muscles used to breathe. Weakness in these muscles can cause respiratory problems, making breathing very difficult. Respiratory problems are among the most serious symptoms of ALS. Early respiratory symptoms: shortness of breath with activity, difficulty breathing while laying flat, easier to breathe while sitting up, waking up feeling fatigued along with morning headaches, weak cough, chest congestion, and difficulty clearing secretions. Deep breathing exercises. These exercises can help use full lung capacity and help compensate for weakened muscles. So if you sit at a table, hunched forward, supporting your weight on elbows or hands, then you take a deep breath in through your nose if possible, hold for a few seconds, and exhale slowly while your through your mouth while your lips are pursed. And you want to repeat this several times. So I'll turn the camera back on. So that's pursed lip breathing. So what that looks like is you breathe in through your nose and then by doing this, you're creating a little bit of resistance in your airway, and that helps get all of that air out a little bit easier. So let me take my face back off. Cough techniques without assistive devices. So what a huff cough is you sit straight up with your chin tilted slightly up and your mouth open. You take a slow, deep breath to fill the lungs, hold for 2 to 3 seconds, and exhale forcefully but slowly in a continuous exhalation to move mucus. So basically, whenever you're doing this, you're almost saying the word huff. So you take that deep breath in, huff, like that, and that will help get some of those secretions moving. Cough techniques without assistive devices, an abdominal thrust. So prior to a timed cough effort, the caregiver applies rapid, forceful pressure to the upper abdomen in an upward and inward motion between the bottom of the breastbone and the navel. So by doing this, you're kind of getting your hands underneath the lungs and you're kind of giving that thrust upward, and that should help begin to move some secretions. Cough techniques with assistive device, a cappella. So if you look at the little girl in the picture, she's holding that green football looking thing. That is an a cappella. So you would sit up with good posture. You take a deep breath in and hold for about 3 seconds. Place a cappella mouthpiece in your mouth. Exhale as much as possible, but not forcefully. Repeat this process for 10 breaths. Try to resist coughing during this process. After 10 breath process, perform 3 huff coughs to bring up secretions. So what this little device does is as you're breathing out, the air is stopped, creating a vibration in your lungs. So as you're breathing out, it's sending vibrations, and that's helping to loosen up all the mucus in your lungs. Cough techniques with assistive device, chest vest. So if you look at the lady in the picture, she has that purple vest on. She has 2 tubes coming out and into the machine. The vest is a machine made up of 2 parts, an air pulse generator and an inflatable vest that wraps around the chest. So what happens is that vest will fill up, and then it'll send those pulsating puffs of air through the vest. And so that causes that vibration, just like in the a cappella, but this one is the patient doesn't actually have to make the effort to do it. It's the vest is doing all the work. The vibration of the vest against the chest wall helps loosen the mucus. Secretion clearance. And if you look at the left-hand side, sorry, that is a picture of a suction machine. Most commonly used is the yank hour, which the picture on the right-hand side, you can see they're putting the yank hour into the lady's mouth, and they can put that anywhere in the mouth toward the back of the mouth to get any secretions and mucus out of there. What is a BiPAP? A BiPAP delivers pressurized air directly to the upper airways. There is one pressure for inspiration and a lower one for expiration. The mask that fits over the nose and mouth is used for the delivery of pressure. The positive airway pressure prevents collapsing of the upper airways, allowing the patient to breathe more easily. The BiPAP is very intimidating. Whenever we think of a breathing machine, we think this is worst case scenario and it's scary. So here are the 2 most commonly used BiPAPs. There's a ResMed AirCurve 10 and the Respironics Dream Station. This is a size comparison. So on our left-hand side on both pictures is the ResMed machine. In the middle, we have a tissue box. And then on the right-hand side, we have the Dream Station. So you can see the Dream Station is not a whole lot higher than what the tissue box is. The ResMed is about the same length of a tissue box, but it does have a little bit of height to it. So that is what they look like. So next up, we put in a video of how loud these machines are. I think this is the most scary part, and the most common question is, oh my gosh, is this going to be loud? Is it going to be intimidating? And it really isn't. They're very quiet. So I'm going to play the video and you guys are going to hear it running. In the beginning, you're going to hear like a louder puff, and that's just the mask seal getting a good seal on the face. So what you heard there was Marla had taken 2 breaths in. So that was the air being sent in. When she breathes out, it gives her a lower pressure. So the BiPAP breathes with you. You don't have to sync your breathing with it. It breathes with you. On our next screen, we have the Dream Station. We did the same thing with this, so you could hear it again. In the beginning, you're going to hear that loud suction. That's just the mask getting a good seal. So we're going to play this, and you're going to hear her take 2 breaths in this video. And so that is what the machines sound like. They're not very loud at all. If you have a bed partner, they will barely hear this thing running. Basically, you can hear when the breaths are taken in and out, but otherwise there's no other tone that comes out of the machine. Next up, I had Marla try on some masks. I think this is also another very intimidating part of getting a BiPAP machine. Is the mask itself. So we're going to start off with the bigger, bulkier masks because these are most likely the ones you're going to see. So I'm going to play this video. So as you can see, there is a lot of straps with this. I put the straps over her head. So she has one strap that goes around the top of her head. She has one that goes around the crown. And then there's the bottom strap that clips in. You can see I'm showing you it's a hook and it fits onto a peg. Marla has the mask on. You can see the top head straps, the bar between the eyes, and then it goes the whole way down around the nose and mouth. So it is a bigger, bulkier mask, and this is intimidating. Nobody wants to have a mask this big and bulky, but this is the traditional mask that everybody remembers seeing and is scared of. Next up, we have another traditional style mask. So I'm going to play this video. So this one, again, you can see all the headgear associated with it. Goes around the crown of the head. The 2 straps come around the forehead. And then this one just had on one side, you looped it through. You can see there's your top between your eyes. And then that's where it hooks. You can see again, it's very big, very bulky, a lot of headgear. And a lot of times ALS patients will not be able to put this mask on themselves. So our next mask is an updated full face mask with magnets. So we're going to play this video and you're going to see there's no bar between the eyes. There's nothing on top of the forehead. So the mask starts at the bridge of the nose and goes down around the mouth. And then you can see it has a magnet. Look at how quick that just magnets to. So you can see Marla showing. And you can see how easy we take that off and it snaps back together. It's not quite as bulky as the previous ones. Marla's going to do this herself. No, she does not wear a BiPAP. This was her first time putting this mask on, and you can see how quickly she was able to maneuver that mask. Our next one is a low profile full face mask with magnets. So for those of us who are claustrophobic, this is the solution that they have. There are different styles of this. I just picked a couple different masks that we had on hand. But you could see your tubing would come out of the top of the head. The mask starts underneath the nose and goes down around the mouth. You can see that again, we have those magnets that they clip on super easy. Again, this is the first time Marla ever had this mask on, and you can see how easy it was for her to adjust it. So that is another option to the full face mask. So we have a lot of options. So what will happen is a respiratory therapist will come out, fit you with mask, go over the machine with you. And it's not as scary as everyone thinks. Like initially when someone says, well, you need to get on a BiPAP, it's a scary process, but really we work with you and we get you the mask that fits the best and is the most comfortable for you. And then the pressures, as far as that goes, that too is adjusted accordingly. And that is all I have. I would like to thank you for your time, and thank you for joining us today. If you have any questions, I will be happy to answer those for you. Thank you. Have a good day.
Thank you, Kimberly, for sharing your insights with us today. As we learned in her presentation, there are a number of considerations for our community when it comes to breathing support. As a reminder, if you have questions for Kimberly, feel free to type them in the chat below. Next up is a presentation entitled Comprehensive Care Includes Respiratory Care. Our presenter is Carol Chieffe, a nurse at the Allegheny Health Network ALS Certified Center of Excellence. Carol's cared for thousands of people living with ALS over the years and will share her perspectives about how respiratory care fits into a person's comprehensive care management plan. Let's hear more from Carol now.
Hi, everybody. My name is Carol Chieffe. I'm the registered nurse at the Allegheny ALS Center. And I want to thank everybody for joining today, coming in to listen. And we're going to talk about respiratory care in the setting of comprehensive care at the clinic. But I also want to give everybody a little bit of a background about ALS. You get diagnosed and we kind of get past all that very, very quickly, and no one really gets the chance to worry about that or even learn about that. So I'm going to include that in my talk today, and we'll go then later have a question and answer period if there's more questions that you have thought about during the way. Next slide. So just a little overview of ALS. What ALS stands for is amyotrophic lateral sclerosis. And that's a disease of motor neurons in your central nervous system. And what neurons are actual nerve cells. We have motor nerve cells and we have sensory nerve cells. And they call it lateral because it occurs in the lateral horns of the central nervous system. It was first described by a Dr. Charcot in the 19th century, who was a French neurologist who was pretty famous for describing a lot of different neurological diseases. ALS, MS, Charcot-Marie tooth disease, a whole lot of different diseases. Not that he had treatment, but he noticed that this progressive weakness in different patients was all different, and went on to discover that's because they were all different diseases. ALS became very famous when Lou Gehrig, the New York Yankee, was diagnosed with ALS. And so a lot of times we heard that it was Lou Gehrig's disease that a person had, but really it's ALS that they had. 90% of all cases are sporadic. There is a 10% case of ALS that is hereditary and familial, and we can test a gene for that, but the majority are not, and more males are affected in this disease than females are. Next slide. Next slide. So I want to talk about why comprehensive care is so important in ALS. Generally, when you see a doctor, you and maybe a significant other, your support system, go in, see a doctor, talk about what's going on, and you go home. But what comprehensive care is it's a multidisciplinary care that all occurs in one office visit, one intensive visit. And not only do we take care of the person with ALS, the family is also included in that comprehensive plan. And when you're there, you'll see the provider, whether that be the physician or the physician's assistant or the nurse practitioner, but the person who writes all the orders and listens to us when we talk about what we found a patient or the family really needs. You'll see a speech therapist, a registered dietitian, a respiratory therapist, the physical therapist, the occupational therapist, and the ALS Society, which actually is our social worker, and the RN. And after each person sees you at the end, we all sit around and talk about what's the best plan of care for you as an individual or for your family. And it's been demonstrated so that this really improves the quality of life in patients with ALS, but there's a possibility that it actually includes a prolonged survival in those that have been diagnosed and are seen in comprehensive care. So much so that it's now considered the standard of care for all ALS patients by the American Academy of Neurology. So it is really important that you come to a comprehensive care center for your care. Next slide. So what happens with these respiratory issues in ALS? Well, the respiratory issues, they're not just breathing problems. So, and what that means is a breathing problem is generally a problem with your lungs. In ALS, there is not a problem with your lungs. Your lungs work just fine. What happens is the muscles that allow you to breathe well no longer work. So the motor neurons start to die in the nerve called the phrenic nerve, which causes the diaphragm to move up and down. And without our diaphragm moving up and down, we just don't bring in enough air. Generally, oxygen is never needed because you don't have a problem with your lungs. If you do, that's handled by a pulmonologist, and it's for other reasons, where you have COPD or you have fibrosis caused by another disease. So we want to keep your lungs healthy. We want you to get your flu vaccine, your pneumonia vaccines. Keep up on those because it's your lungs that need to be healthy. We can help the poor muscles and make you more comfortable in getting enough air in and out. Next slide. So obviously that's a typo. I'm really sorry. It's what do we need to help you breathe? So it's important to be seen in the ALS clinic for comprehensive care, mainly because we can measure with a respiratory therapist to measure your breathing pattern or the amount of air that you can move in and out on your own without any assistance. That is mandatory. Those spirometry tests are mandatory for us to get anything approved for non-invasive ventilation. And I'll talk a little bit later what non-invasive ventilation is. But another reason to be seen in the ALS clinic is we have very novel ways to help decrease excess saliva. So when you have all this extra saliva and you're having trouble swallowing, it just gets in the way. And that's not anything that helps. So helps a person who's having trouble getting enough air in anyway. And then we can also get mechanical assistance for airway clearance. A lot of general neurologists don't even know what that is. So what that is we call it a cough assist. It has many different names, but it helps for you to get pressure on your chest to bring up secretions. And then there is, if you need even more help, a suction machine to get the back of your throat cleaned out. And then we can order the non-invasive ventilation without having a huge pulmonary appointment and the pulmonary testing that they do in the pulmonary lab. Next slide. So airway clearance. You really need good muscle strength to generate an adequate cough. If you remember, anytime you've been sick with a prolonged illness that makes you cough, your chest muscles and your stomach muscles hurt because we're working them so much more coughing, because it's those muscles' strength that needs us to work very well to produce or generate a good cough. We need to keep air secretions at a bay. That's, why we use sometimes patches or drops, a home suction machine, a lot of things. And then a lot of times we use the cough assist or the mechanical insufflation and exsufflation. And that's what we call as a cough assist. There's a lot of different ones. They use it also a lot in cystic fibrosis. But we're able to tailor this to our patients' needs because we have such an input of not just a physician and you talking, but the respiratory therapist and your family and the PT and OT. Next slide. So what is non-invasive ventilation or a respiratory assist device? Well, those are fancy names for what's called BiPAP. And BiPAP is bi-level positive airway pressure. And that pressure helps to put air into your lungs as on inspiration. It's considered standard of care now for all patients with ALS once they hit a certain level of on one of their spirometry tests. And it's very small, it's about the size of a lunchbox. And the pressure's put through into your lungs through several different ways. Some people use a mask, others use a nasal mask or nasal pillows, and some can use nasal prongs. It's very different than CPAP because CPAP delivers the same pressure, inspiratory and expiratory, where BiPAP has a higher pressure on inspiration, like our normal breathing does, than it does on expiration. Otherwise, sometimes it's very hard. Sleep apnea, they use CPAP because they're not breathing at all, they're apneic, where BiPAP is used in ALS because you have a better ability to breathe out and in, because exhalation is more of a passive movement of air than the inspiration is. Next slide. So we do have new generations of respiratory assistive devices, and they're called AVAPs. And AVAP, I didn't realize that they were called that, but the brand names are the Trilogy, the Astral, and they're really a pretty unique instrument to supply assistance on breathing. They are volume targeted so that if you need less inspiration force in at one time during the day, it's less. If you need more, it's more. So it's volume targeted. They're extremely portable. They can actually run on a battery, so you can go places. And they have this very unique feature of a mouthpiece ventilation, so that if you're out and about, you're not hooked to a mask, but you put this mouthpiece in, it almost looks like a flute, and it will supply the inspiration and expiration pressure that is needed. Unfortunately, a lot of insurances have limitations to these. Some insurances make you have tried BiPAP and failed it, but not just tried BiPAP, but several different ways that the BiPAP is administered. So we do try very hard to get these for people, but it's never an easy event. But one of the things that we have the advantage of is, again, that comprehensive input to the insurance company, that I have many, many, many more things to fight with the insurance with. Next slide. So what does the future hold with ALS? You know, one of the things, there is a national registry for the ALS, for patients with ALS, and I never understood why that was such a big deal, but I wanted to explain that. So when there's a national registry, there's an actual count of the amount of people that have ALS. It's not an estimation. And with that, the Department of Defense, which oddly enough does a lot of the money distribution for research, can identify, well, we have this many people in that have ALS, and we need more research, so this much money will go to them. And with that, there's over 600 clinical trials currently worldwide looking at ALS. Now, it's not all looking at disease modifying treatments or respiratory issues. It looks at quality of life, different drugs, slowing it down. What can we identify a true cause of this disease? So that's one of the reasons it's very important that there's a national registry, because then that ALS has a true line item when it comes to distributing money for research. Next slide. So let's just review. Comprehensive care is considered the standard of care. So nothing less than comprehensive care is really to be completed for ALS patients. Now, that's not saying that you can't see your home local neurologist, but we'd like to, at the minimum, see you twice a year for consultation so that we can help direct your local neurologist. In our clinic, we generally see our patients who want to stay with us in the comprehensive center every 3 months. It is improved, it's individualized care, but I also like the fact that we include your family, your significant others, in what their needs, what they might need. Out of our comprehensive care and listening to our patients, we actually have a support program that's done online for the patients. And we did it online before COVID ever hit, because we understand that caregivers of patients with the ALS can't just leave to go to a meeting. They're the caregiver of people with MS. A comprehensive care also results in decreased visits to different specialties. You don't have to make a visit in to see the dietitian, or a different in to be evaluated for some brace or such. And the other is you have one contact to coordinate that care. Any issues that you're having, people reach out to me, we discuss what needs to be done, and then I contact and coordinate all that care for you. So you're not making several different phone calls. You're not frustrated, because I know as a patient, trying to get calls into a doctor's office can be really, really frustrating. And this way you're provided with my chart number. You can get my direct phone number or my admin, Lori's direct number. And there's one call, and that's all. Next. So I want to thank you all for listening. I'm very passionate about caring for my patients and families affected by ALS. And if you have any other questions, please save them to the end when we have our question and answer session. Thanks so much. Have a great day.
Well, we're going to go ahead and move into our Q&A session for all three of our presenters today. I know Larry is on. I believe, Carol, did you join us? I think I saw you join in. Give Carol a minute. And then is Kimberly still on?
Hello.
Hey, Kimberly. Perfect. All right, well, let's go ahead and get started. We had a couple of questions come through the chat, and I have a few others that came in advance. So I'm going to get started with the questions that were in the chat. Larry, you had mentioned this earlier in yours. Can you talk a little bit about what's going on with the BiPAP recalls, and is there more that folks should be doing other than registering their device?
Yeah, first and foremost, register your device, right? And it sounds like that's what this person did. For our CPAPs and BiPAPs, again, we classify the devices into non-life supporting and life supporting devices. CPAP and BiPAP would be classified as non-life support, right? Our suggestion, and I can only tell you what the manufacturer suggests, is to discontinue use and discuss with your physician the benefits and risks to continuing therapy. So I would venture to say that for the ALS population, the vast majority, if not all, of the pulmonologists out there will suggest that you continue using your CPAP or your BiPAP. For ventilators, that's different, right? So for your Trilogy ventilator, which is just to be upfront, that's also on the recall list as well. The Trilogy 100 and 200, not the Trilogy Evo, that's a different device. The Trilogy 100 and 200, our suggestion is to discontinue use. And again, discuss this with your treating physician to weigh the risks and benefits. I'm not sure if that answered your question or you have a follow-up question, but if you registered your device, that's the best thing you can do. And at that point, quite honestly, it becomes a waiting game to when you're going to get a replacement device. And our intention at Philips is to remediate or replace or repair all affected devices with a recall.
Thanks, Larry. We appreciate that. I hope that was helpful.
May I add something to that?
Please.
If it is an AVAPS device or something along those lines, my understanding is that they will be sent to the DME, and the DME would come out then and replace that. Is that correct?
That's correct, Kim. So the advanced therapy devices, so I was talking BiPAP, BiPAP S and CPAP, BiPAP ST, BiPAP AVAPs, BiPAP auto servo ventilators, ASVs. Those devices will be remediated by the DME. So those devices will be sent directly to the DME. The DME then will contact the patient to replace it. If it's a CPAP or a BiPAP, Philips, for the vast majority of customers that I deal with, those customers have chosen for us to work directly with the patient. So those devices will come directly from us. Advanced devices from your DME. Does that answer your question, Don? I'm sorry, Kim.
Excellent. Thank you. And just for clarity, I think most of us know what this means, but DME is durable medical equipment. So a durable medical equipment provider is what they referred to when they said DME. I'm going to ask you another question that came through on the chat, and I'm going to kind of throw this out. I think that really this could be for Kimberly or Larry. What's the difference between the CPAP and the BiPAP? The BiPAP seems to be pretty loud, is what the person who asked this question. And so they just wanted to understand a little bit more about the differences between the two devices.
So what a CPAP is it is continuous pressure. So what that means is it would give you the same pressure throughout. That is typically used for sleep apnea. What a BiPAP is it gives you one pressure for when you're breathing in. So it would be a higher pressure and a separate pressure when you're breathing out, which would be a lower pressure. And it's a lot more tolerable. It'll breathe with you. One of the misconceptions is you have to sync with the machine, and that is not true. The machine syncs with you. Does that answer your question?
Hi, this is Carol. And another issue with CPAP and BiPAP, a lot of patients get confused, but a CPAP requires much more testing to be completed, including a sleep study to be approved by insurance. A BiPAP does not.
Thanks, Carol. Appreciate that. All right, next question. Carol, while we got you, welcome. We're glad you were able to join us. For those of you who didn't know,
Hi, everybody.
She's on vacation and she's joining us via phone today. Carol, we got a question in advance. What should I do if my mask or equipment's not really helping?
If the mask is not helping?
If the mask isn't fitting well and the device doesn't seem to be helping them with their respiration, what would you suggest they do? Who should they talk with? How should they go forward?
Right. So a lot of times when patients feel that the machine isn't working well, it's because the mask doesn't fit. We have great support with our respiratory therapists that go out with the DME and also the respiratory therapists that come into clinic. We have switched a lot of people to nasal pillows, and all of a sudden they feel so much better, and they feel the machine works so much more for them. So all you have to do is let us know, and we go from there.
think that's great advice. So if you ever
Hey,
have a
Ryan,
problem,
do you mind if I add a little bit to that just as well? Because,
please.
from our devices, whether we're talking a CPAP, a BiPAP, a ventilator, whatever, just about all the devices nowadays, and I don't care what manufacturer you look at, right? They all have the ability to get data transmitted from those devices remotely. So the CPAPs, the BiPAPs all have modems in it. You can add a modem to a ventilator as well, so that we're getting connectivity and you can log into a web-based platform, and we can see that mask leak. And I think from a patient standpoint, it's extremely important that the sooner the better. If you're having an issue with your mask, you need to get that addressed right away, because if you don't, it's going to lead to non-compliance. You're not going to get the benefits of the therapy. And all manufacturers out there have a mask satisfaction guarantee. So within the first 30 days of therapy, for any reason, and I can only speak for our program, right? So during that first 30 days of therapy, if for any reason you're experiencing a problem with the mask, we'll go ahead and replace that mask, not directly with the patient, because we don't deal directly with the patient, through the durable medical equipment. So like a Laurel Medical, we will replace that original mask at no cost to them. If for some reason you could not tolerate that mask. So it's important, vital, that if you've got a leak, and sometimes it's as simple as going from a small to a medium cushion or a medium to a large. And one misconception, everybody thinks you need a lot of people think you need full face masks with non-invasive ventilation, and that you can get by with a nasal mask as well. All the therapists out there, they're good, they understand that, and they'll work with you on making sure you get the most appropriate mask.
Great. Thank you, Carol and Larry. So all right, next question. I'm actually going to ask Marie, our Director of Care Services. Marie, are you still on the line? Can you come back on and unmute? I've got a question for you.
Hi, everybody.
Hey, Marie. So Marie, we talked a lot about different devices today, and I think most people on this call know that we've got an equipment loan program here at the chapter. Can you tell us a little bit, do we have respiratory equipment in the loan program? And if so, how would people access that?
That's a good question. So we do have some respiratory equipment in our loan program, but we utilize that as a backup, not as a primary device. I think everyone heard on all the presentations today that the respiratory equipment is a little bit more advanced and needs more monitoring than some of the other items in our loan program. We really think that a respiratory equipment requires that specialized monitoring from your physician, respiratory therapist, pulmonologist. So again, it's not provided as your primary source of equipment for respiratory. We do have social workers that are assigned to each person and family registered with our chapter. So that person can work with families and the clinics and other professionals to help get the person living with ALS the needed equipment. But most of the time that's through their insurance.
Thanks, Marie. On that front, Kimberly, I'm going to direct a question to you because you work for a durable medical equipment company who provides a lot of this equipment. Can you tell everyone, so once the item is purchased and they have it, kind of what is the role that you would play as respiratory therapists working for a durable medical equipment company in the long term?
So in the long term, I have set up cough assists, I have set up BiPAPs, suction machines, whatnot. In the long term, I try to keep open lines of communication. And then that way, when there is a problem, like if the mask isn't fitting, I'll look at their data, see, okay, is it a mask leak? Is it the actual mask? Is it a pressure issue? And things along those lines. I try to explain things as best as I can and educate thoroughly. And I'm always a phone call away. So it's, if they have a question, just give me a call and we'll figure out what we need to do next.
Excellent. Thank you so much. Question related maybe to the loan program, but also this is really maybe for all three plus Marie that could answer this question, but let's talk a little bit about insurance when it comes to these kinds of devices that we've been talking about. Are they covered? What, how do we go about getting them? So can we talk a little bit about what the cost is and how that can be provided for either through insurance or other means?
This is Carol. I have never had a denial from an insurance company for a patient who needs respiratory equipment. So no matter what, we work very, very hard with your insurance to get you what you need. And I've never had someone come back and say, well, too bad. So it is very easily covered.
Yeah, just to add into that, what Carol had mentioned from whether you're talking a BiPAP or a ventilator, right? There's two different pathways to get those covered.
Right.
May I ask a question?
Yes, of course.
So I'm sorry, it's not as advanced as a lot of the equipment that you're talking about, but it is respiratory related. So I'm just curious about whether you've experienced that your patients who are prone to allergies or asthma can be more challenged as they move through their illness, and how does one determine whether the issue is a muscle related failure, as you've been talking, or really an allergy issue?
So from the standpoint of that, you already have if not all allergies cause lung issues and breathing issues. It can cause a lot of secretions. So we always take that into consideration with secretions, and we treat allergy secretions in addition to regular secretions pretty much the same way. We encourage patients to stay on their allergy antihistamine medication. It's the difference in, is it your asthma versus is it your lungs, is upon your spirometry. They can look right at that. But anybody that has severe enough asthma also works with a pulmonologist. So we work very closely with the pulmonologist.
Okay, thank you so much.
Sure.
Can I go back to the insurance? Thank you for those questions, but can I just kind of go back to the insurance question, just to add a little bit more to what Carol said. So usually I see that it's not that insurance will not cover it, but sometimes individuals have insurances so that there's a copay involvement, or traditional Medicare, if they cover 80%, that there's a 20%. So I just want to let you know how the chapter kind of helps with that, and and as always, talk with your clinic if you're attending clinic, and they're also extremely helpful with that. But the chapter does provide a chapter grant that helps with copay assistance for equipment. The issue is, though, oftentimes our chapter grant is typically a $2,000 grant, and some of the equipment relating to ALS can be a costly monthly fee. All the machines or equipment start adding up. So again, one of the things that we've been working with as a chapter is that we added some social workers, and each social worker is assigned a family, and they will not tell you what insurance to choose, but they can give you guidance and resources about coverage. The Pennsylvania has a program. It used to be called a prize. Now it's called PA Medi, that offers insurance counseling. So again, there's things out there that can help with that. And also the chapter does assist families as needed.
And then to add to that, Marie, is that patients that are not on Medicare but are covered by commercial insurance, a lot of times companies that, I work for AHN, so AHN carves out certain things to save overall costs. So you might have a company that generally limits physical therapy or occupational therapy or durable medical equipment to so much money a year or so many visits of the respiratory therapist. So that's where we sometimes run into issues as well. And we don't know that until either myself or the respiratory company speaks with the insurance company, because it's just what your human resources or your company has chosen to try to decrease to save costs of insurance.
Thank you both. Larry, I know you touched upon this a little bit during your presentation, but I'm going to ask you to maybe go a little bit deeper about starting with the equipment a little earlier in your ALS diagnosis. I know that's something that Philips has been focusing on. So can you talk a little bit more about that, just to give folks an idea of maybe?
Yeah, maybe combining, earlier intervention, and I think, we're on the subject of insurance, right? So how do you get a patient a BiPAP if their FVC is at 80% predicted? There's ways around that. I know we had Dr. Lisa Wolf from Northwestern University, who's one of the key ALS, physicians in the United States, come in, and she has some ways around that to try to make sure that she gets her patients on therapy earlier. And there are some other countries that, Canada for one, right? You get an FVC of 80% predicted, you're going on non-invasive ventilation. Again, this is with a diagnosis of ALS. But there are some challenges, but the study did show that you definitely can get an increase in survival rates, or survival duration, I should say, almost doubling a patient's median survival time by implementing non-invasive ventilation at 80% predicted versus waiting till they're at 50%. And by the way, to go from 80 to 50% in this study, it only took the patients 4 months. So it wasn't because we got them on therapy earlier that they lived, their survival rates were longer. It was the benefits of the therapy, and also using it longer and more. 8 hours a day is basically sleeping with it. And then using their cough assist daily. How many times a day? They didn't track that, but the patient was using their cough assist daily, and IV 8 hours a day, and getting it at 80% predicted for their FVC. Their median survival time increased from 15.3 months. So again, standard of care in the US, 50% predicted, 4 hours a day using the BiPAP. That's it. We get that. 15.3 months was the survival, the median survival time or duration. 8 hours a day, so double the use on the NIV, start them a little earlier on their NIV, get them using cough assist, it can go up to almost 31 months. And using remote patient monitoring, I think that's something that I think we all understand nowadays is becoming more and more popular, right? Telemedicine, if you will. So the ability to monitor these patients in their homes, or looking at their data, having call centers, things of that nature that I know Philips is looking at to try to help ALS patients with, managing their care and trying to take some of the load off of, maybe having to go into a sleep lab for a titration of their device to see what pressures they need, because keeping in mind, when we set a patient on a BiPAP, that is a fixed level of pressure support. What you get today, or what you're getting today, might not be what you need 6 months from now with a progressive neuromuscular disorder. So if we have, and I think it was Carol that mentioned AVAPs and volume targeted type algorithms that are in some of these devices, where those devices are essentially like having a little respiratory therapist in the machine, and they're adjusting the pressure up and down according to what the patient needs. So there are a lot of tools that we can use to make things much better for our ALS population.
Thanks, Larry. So we got another question that came in through the chat from Brett and Janine. They're asking, do Medicare Advantage plans limit DME and or therapy visits to manage cost? And also, do the supplemental coverages to Medicare limit DME and or therapy visits? So I'll throw that out to any of you if you want to take it.
So straight Medicare and a supplement does not. If you have a Medicare Advantage plan, they do. When that becomes a real caveat is patients who are on the IV medication need to be on a Medicare Advantage plan because of the Medicare does not cover home infusions. So there's a sticky wicket with all of that, yes.
Excellent. Thank you. So last thing I'll just state here, I saw somebody asked about getting a copy of the breathing exercises that Kimberly provided in her presentation. She's going to email that. She put her email in there, so I'm sure she'd welcome anyone who wants to email. But I also want to let you all know that the majority of our presentation today was recorded and will be available with the exception of Larry's piece. Unfortunately, this company doesn't allow for those to be recorded, but both Kimberly and Carol's presentations, along with this Q&A, will be available on our YouTube channel. So you can always take a look back there. But again, Kimberly was kind enough to provide her email address if you'd like to email her directly. Well, with that, let's go to our last question, which is the same question for all of our panelists. And it's something I ask at the end of all of our symposiums. What do you think is the most important thing, or what's the one takeaway that people should take from this? So what do you either see as a future trend or something that you think is really important that people should consider or know when it comes to their respiratory health and ALS? So I'm going to go ahead and start. Larry, you're off mute. So I'm going to put you on the spot and ask you first.
No, that's great. I think you probably are going to guess where I'm going to go, right? Try to get on therapy early, right? Work with your physician, work with your multidisciplinary team from a respiratory standpoint, work with your respiratory therapist. I know Kim said she's just a phone call away, right? Any issues that come up, they need to be addressed right away. If it's intolerance, pressure problems, mask issues, I think it's important that you reach out and you seek help as quickly as you can get it, because the longer you let those things, go on, the less likely you are to use your therapy and ultimately benefit from your therapy. So I can't stress enough early use, even if you're feeling good. I tell people, sit there, watch your TV, put your mask on, use it for a half an hour, use it for 20, 30 minutes. You got to get used to the therapy so that you can benefit from it when the time comes that you really, really do want to use it and do need it. You're already past that acclimation point. You've gotten used to using it.
Great insight. Thanks, Larry. Carol, I'll jump on over to you. What insight or what do you hope people will take away regarding their respiratory health?
I think the biggest thing is please be honest with us. And sometimes patients have difficulty with managing all those different phone numbers and phone calls. I was very nicely called once the quarterback. I will be glad to quarterback for anyone. I don't want you to ever think that I'm going to get angry or mad because you can't remember what your respiratory therapist's name is or such. I will make those phone calls for you and get you the help that you need. You don't have to wait for your 3-month appointment.
That's great. Thank you, Carol. And I think the same goes for the nurses who are working in the other 3 clinics that we work with throughout Western Pennsylvania.
And I'm sure it is. It's just the way the nurses kind of are.
Yeah, that's right. They're always the helpers. And then Kimberly, I don't know, what would you hope people take away today related to their respiratory health and ALS?
I would agree with Carol's answer, just being honest. As a respiratory therapist, I think one of our key characteristics is our patience. We can listen and we're very patient. If you're uncomfortable, tell us. Let us figure out a solution together. Like, we're a team. And I always tell everyone, I'm just your cheerleader. You're the team. So whatever we need to do, I'm going to cheer you on and I'm going to back you. And so I feel that if you just establish that relationship with your care team, and that we're all here to help you. So don't feel that you ever have to withhold information. If you hate a therapy, you hate it. Okay, let's try to figure something else out.
Thank you. And Marie, I'll throw it to you. Is there anything that you want to add to these amazing answers that we just got from our 3 panelists?
No, I totally agree with everything that they're saying. I guess from my perspective, I come more from the social work and therefore the insurance coverage. So again, if you're having difficulty, if you're having questions about your coverage or how the chapter can help, please don't hesitate to reach out to myself or to the social workers that are assigned to you. We're all here. to help, whether it's if you're attending a clinic, any of the clinic staff are there to help. Your DME providers, they're there to help, and just call and reach out, and we'll do our best.
I'm going to make one quick plug here, going back to a little bit of what Carol talked about, which is working with your multidisciplinary team at your ALS clinic. If you're not attending an ALS multidisciplinary clinic, I would highly encourage you to think about it. We have them here in Western Pennsylvania. There's one in Johnstown, one in Erie, and two here in Pittsburgh. So Carol's part of one, and then there's another one at UPMC. So if you're not currently working with a multidisciplinary clinic, do that. And just a little background, the ALS Association is funding all 4 of those clinics. Your insurance covers the cost of working with the neurologist who runs each clinic, but all those allied health professionals, that doesn't come from your insurance, that's us. We provide that money to make sure those people are there, because multidisciplinary care is really the best way to address an ALS diagnosis, making sure you've got all the providers working together in the same room at the same time, having conversations about how to treat and how to best address your health. So if you're not, I definitely encourage you to seek out more information. Feel free to reach out to the chapter if you don't know. And if you are, I think going back to everything that Carol and Kimberly and Marie and Larry said, if you're having problems, reach out. Don't wait for your 3-month appointment. They are there to support you in your health journey. And with that, I think that wraps up our symposium for the day. I want to say thank you again to all 3 of our panelists, Larry, Kimberly, and Carol, and Marie. Thank you as always for jumping in to provide your expertise in your long tenure working with families with ALS. I saw one last question come through. It's what's the best way to reach Carol directly? I will get you her information so that you can reach out to her directly.
Thank you.
All right. With that, thank you, everyone. Have a wonderful weekend. Happy Halloween if you're celebrating, and I hope you give away lots of candy this weekend. Bye, everyone.